Hello, I'll be talking about tendon transfer for the median nerve lesions, and we will talk about high and low median nerve injuries and what tendon transfer options are available for such cases. When we see the role of tendon transfers, they may be required in three situations. First of all, if there is no recovery after a repair, which is quite possible because all the nerves do not recover perfectly all the time. And we can see for median nerve, even a good repair at the arm level, in 25% of the patients, you would require some kind of tendon transfers. When the patients present late or to augment a partially recovered nerve. So when we combine these situations, you would see that when you are dealing with nerve injuries, very often you would require help of tendon transfers to get a good function. So even with lot of nerve transfers available, they still continue to have a major role in nerve surgery. And one can be sure that they are very time tested and they give quite a good result and patient can go back to the function quite often. When we talk about nerve injuries, there are two functions which we desire from the nerve. One is the motor function and the second is the sensory function. The sensory function can be restored only by nerve repair. So that means the nerve repair has to be the most important focus. Especially for the median and ulnar nerves, the areas, the sensation supplied by these nerves is so important when we do all the activities of the hand, especially the median nerve. Because if the sensation is not present in the index and thumb region, the person would not be able to use his hand quite well. The motor function can be very well replaced by doing tendon transfers. So if you have a nerve like radial nerve where the sensation is not so important, you can actually put the tendon transfers little higher up. But for median nerve and ulnar nerve where sensation is important, the nerve repair has to be the first important thing and the tendon transfers can be used to augment the function further. When we plan the tendon transfer for any nerve injury, there are three basic questions what one would ask. What is lost? What is required and what is available. Now let us put this to the median nerve. In median nerve palsy, if the injury is at a higher level above the elbow level, you would have loss of wrist flexion because FCR and palmaris longus are paralyzed. All the FDS are paralyzed. For index finger, both the FDS and FDP are paralyzed, resulting in the pointing index. We often tell for median nerve. And the thumb flexion is lost because the FPL is paralyzed. Also, there is loss of thumb abduction and apposition. The last being the feature of the lower level of median nerve injuries also, and the commonest reason for requiring tendon transfer. In low median nerve lesion, all these functions may be intact and person may be having only deficit of thumb apposition. And as I told earlier, the sensation is again very important, which is lost. What we require, we don't require to correct all these deficits. It has been found that the wrist flexion with FCU is quite sufficient. The FDP flexion is sufficient to move the index, the little finger and ring finger, and most often the middle finger completely. You would only require to restore flexion of the index finger, thumb flexion, and thumb apposition. So these three are the deficits which we want to correct by doing tendon transfers. Now, what is available? We have all the muscles which are working with the ulnar nerve and the radial nerve. We have the side flexors innervated by the ulnar nerve, which can be used to flex the index finger. We have brachyradialis and ECRL, which can be used to flex the thumb. And we have the EIP and FDS, which can do the trick to get a thumb opposition. So this is the way you calculate what is lost, what is required, and what is available. So you can plan which is best suited for given patient. Let us see an example over here. This patient had a high median nerve injury at the mid-arm level, and this patient presented at 10 months post-injury to us. Now at 10 months, you would often feel like the nerve repair is not going to work. But even then, when you think of median nerve, sensation is very important. So we should try to give sensation by doing a nerve repair. What else is lost? This patient does not have a thumb flexion. He is not able to flex the index finger, the typical pointing index, and he does not have thumb abduction and opposition. What is available? All the muscles innervated by the ulnar and radial nerve are present, so we can use them to do a tendon transfer. We can graft the nerve to get the sensations. For thumb flexion, brachioradialis or ECRL can be used. And for index flexion, we can side hitch to the other FTPs which are supplied by ulnar nerve. And extensor indices can be used for opponent's plasty. This is the nerve graft done for him, almost 12 centimeter nerve gap, multiple nerve cable grafts. This restored decent amount of sensations, which is very important. For tendon transfers, we side hitch the index profundus to the other profundus. Brachioradialis was transferred to the FPL and extensor indicis opponent's plasty. This is the function at 3 years. At 3 years, he has recovered decent sensation, and this is the movement we could get by brachioradialis to FPL. The index is flexing by the side hitching procedure, and we can see the opponent's plasty also has worked quite well. And this is the kind of opposition this patient is able to do. Quite a nicely working opponent's plasty. And seeing this hand, one can be assured that it will be quite a functional hand. So again, important things were sensations and restoring all these movements. Now coming to more complex situations, they become, as far as tendon transfers are concerned, they become more complex if there is a combined ulnar and radial nerve pulses, especially in patients with lower plexus pulses where there is no flexion of all the fingers. So you cannot do the side hitching. The ECRL, ECRB also cannot be used because ECRB will be not functioning in lower plexus pulses. So in such patients, we can go to more proximal options. So this patient has undergone biceps to FDP transfer and brachioradialis to FPL. And this is the kind of function we can achieve in such patients. So this is another way of dealing with more complex situations. A child who had a Volkmann ischemic contracture, where we know that there would be involvement of median and ulnar nerve, and also there will be loss of all the flexor muscles. We generally deal in 2 stages. So first stage, we removed all the scar tissue and did a nice aggressive neurolysis. And then the tendon, the loss can be managed by doing a tendon transfer or by doing a free functioning muscle transfer. Since this patient had a very good wrist extensors, we opted to use ECRL to FDP transfer. And this works quite well. In this child, you see, this is the kind of result we can get by ECRL to FDP and brachioradialis to FPL transfer. And this child was back to activities within few months. And this is the long-term result at 5 years. We can see the child has got good range of finger flexion, all the fingers bending well, and child is able to use the hand quite well. Now, the more common tendon transfer which will be required for median nerve is the restoration of thumb opposition. And it is a part of high and low median nerve injuries. And the main muscles which will be paralyzed will be the abductor pollicis brevis, the opponent's pleusis, and flexor pollicis brevis. This is basically a procedure which is aimed to restore thumb opposition. There are many techniques which have been described, but here we are going to concentrate on the basic principles. First of all, opposition, we should know what is the true opposition. The true opposition is when the thumb goes and touches the pulp of the finger in such a way that the nail plates are parallel to each other. If the nail plates are not parallel to each other and you are doing a tip pinch, something like that, that is not a true opposition. So many patients would be doing like this. This is not opposition. Opposition means you have to touch the pulp and the nail plate should be parallel to each other. It basically is a combination of many movements at the thumb, abduction, pronation, and flexion, which allows the thumb to go and reach towards the pulp of the finger. Almost all the muscles are actually involved in a perfect opposition movement. However, the most important muscle is the abductor pollicis brevis. also helped by flexor pollicis brevis and opponens pollicis. And since it is the abductor pollicis brevis which we are doing the tendon transfer for, or we are replacing, many times the opponensplasty appears to be a misnomer. And that is the reason Kaplan stressed that this procedure should be told as opposition transfer and not opponensplasty. So basically, we are replacing abductor pollicis brevis function. Now, opponensplasty is kind of a refined function of the hand. So it is not good for a bad hand. Suppose a patient has a bad claw hand like this, he will not be helped by doing any opposition transfer, because if you imagine we have done a opposition for him and we have got the thumb out, the fingers are still not flexing. So if the thumb is not meeting the tip of the fingers, the function would not improve. So opposition transfer is the last thing what you do in reconstruction. Once the flexion is achieved, extension is achieved, the intrinsic function is achieved, then only you aim to get the thumb opposition. Also, it is not required for an adjusted hand. That means many of the patients, because of the flexor pollicis brevis, which often can be innervated by the ulnar nerve, they will be able to do a good opposition-like movement and they feel that functionally they are okay. So there is no need to do any opponensplasty for such a patient. And this is commonly seen in patients who have a severe carpal tunnel. They would have got adjusted and they are doing all activities, so we don't have to do transfer for them. Other important thing to remember about opponensplasty is that opponensplasty is a movement which is required just for positioning of the hand. It is not a grasping type of movement. By that we mean is, suppose you want to go and pick up something, you want to bring your thumb out and then go and pick up something. So it is a positioning movement. It is not requiring any much power. So that is the reason why we should not waste a very strong tendon onto the opponent's transfer. It has to be just strong enough to bring the thumb out and allow us to position the thumb out while grasping an object. Now, when you start talking about any tendon transfer, we talk about the donor tendon, the route of the transfer, and the insertion site. So when we are learning, this is the best way to learn all the tendon transfers. What all donors are available, what should be the route, and what is the insertion site. So let us see how it applies to opponensplasty. There are many donors which have been used. In fact, all the muscles around the hand can be used for doing opponents transfer. But the most commonly used are the FDS and extensor indices. How to choose? There are no real papers which compare all the different options, but there is some evidence in the literature that whenever the patient has got some stiffness, it is better to use a stronger transfer like flexor digitorum superficialis. Otherwise, the results are quite same when you use an extensor indicis or an FDS. Also, if these two first options are not available, you can go to the other options like an ECU or FCR or FCU. So all of them can be taken as per the case. Our first choice is the extensor indicis, which is the Burkhalter transfer. And if this is not available or there is some stiffness, we use the FDS. And rest all options are as per that particular case, as we will see in the following slides. Coming to the route, there are 5 ways by which you can reach to the thumb for opposition: subcutaneously, around the pisiform acting as a pulley, or through the Guyon's canal by making a loop of the FCU, through the distal part of the flexor retinaculum, or using the lower end of ulna itself as a pulley. One basic thing to remember is, if the FPB is not functional, that means if there is an associated ulnar nerve injury as well, the pulley must be distal to the pisiform. This is very important because when you require abduction and flexion of the thumb, the pulley must be distal to the pisiform. However, if the FPB is working, that means there is some ulnar function, then you don't require to go distal to the pisiform, and any route would do. You can go around the subcutaneous part of the ulna, you can make a loop in the FCU, or you could go for the pisiform as well. But if the FPB is not working, we must go distal to the pisiform. This is the basic thing to remember and a very important to get a good function. Now, there are 6 different insertion sites which have been described by all the big names in hand surgery: Brand, Bunner, Littler, Riordan, Royal, Thomson, and they take the tendon and put it into various locations like abductor pollicis brevis tendon, over the extensor apparatus, taking around and putting onto the ulnar side. And each author would suggest what they felt is good by that insertion. And sometimes it can be very confusing, but this is a very interesting study by Sky, and they did a kinematic analysis of all these 6 different sites of insertions and to find which one of them is giving best abduction, best flexion, and best pronation of the thumb. It was interesting that none of the insertion sites give all 3 of these. And whenever you are doing opponentsplasty, you actually desire all 3. So none of the sites give all 3 of them. So as per the case, if you require more abduction, then you can go for the Bunnell's type of attachment, where you go and insert onto the ulnar side base of the proximal phalanx. If you want more rotation, you can use the Royal Thomson type of technique, as I shown in the picture. But they found that when you use the Riordan type of insertion, that is the insertion onto the extensor apparatus in line with the abductor pollicis brevis. So this is the insertion of abductor pollicis brevis. You go in line with the abductor pollicis brevis and attach to the extensor apparatus. So when it is attached at this location, they found it produced the best combination of abduction, flexion, and pronation. So that means if you want all the 3 things, this is the best site to insert. And this is what we commonly use. We insert into the extensor apparatus in line with the abductor pollicis brevis, just very close to that. And this is something about the technique. This is the technique which was described by Burkhalter with some important points which I am going to emphasize. The extensor indicis just exactly reaches to the abductor pollicis brevis. So you must always try to take small extra length from the extensor apparatus. Just 1 centimeter will make you much comfortable when you are doing the insertion. The extensor indicis is divided. It is brought onto the ulnar side, just distal to the pisiform, and it is attached to the abductor pollicis brevis tendon or the extensor apparatus just next to the abductor pollicis brevis. An example, an 18-year-old girl, no thumb opposition, the procedure extensor indicis opponentsplasty done, and we can see such a nice result. And this is the result at 6 months, and it is about 10 years since we have done operation for this girl. And interestingly, she wrote her 10th grade exam just at 3 months from the operation with quite a good comfort. And the result, again, quite good result. The next commonly used opponentsplasty is the FDS opponentsplasty, which was popularized by Bunner. We often use it whenever the thumb is slightly stiff. Now, when the thumb is slightly stiff, we try best to get full abduction, but it may not be possible in all the cases. And if the thumb is even slight stiff, the extensor indicis would not reach this thumb. So that in those cases, we use the FDS, and FDS is also more powerful. And this is the kind of result we get with that. One important thing which many times we can forget is the EPL also is a secondary adductor, and in very chronic cases, it starts acting as a strong adductor and it fights our abductor transfer. You always do a rerouting of the EPL. It will make your success rate much higher. FDS we specifically more commonly use for hypoplastic thumbs, where 1 slip goes for opponents and 1 slip is used for reconstruction of the ulnar collateral ligament. And also abductor digiti minimi opponensplasty, the Hubers procedure is again reserved mainly for hypoplastic thumbs to give a good thinner eminence. One other situation where this procedure can be useful is if there is scarring all around the forearm. So then you can use this because all the operation is in the palm and it works quite well. Palmaris longus opponensplasty, Chemit's procedure, we reserve only for patients where the carpal tunnel is being released and patient has got loss of complete thumb abduction. The palmaris longus is taken along with the fascia extension and it directly reaches to the insertion of the abductor pollicis brevis and it gives a reliably good result. And since the tendon is just next over there, it is the best indication for doing the palmaris longus opponensplasty. Now, very often it is thought that whether opponensplasty and claw correction can be done together. Yes, they can be done together, but we should not do opponensplasty first and then claw correction. Or you should do claw correction and then opponensplasty because an opposed thumb is useful only when there is no claw. We can combine both of them. So this patient had a median and ulnar palsy, complete claw hand, no thumb abduction. So ECRL was used for claw correction with the facial lata extension and extensor indices for thumb opposition. 4 slips for claw and extensor indices opponensplasty. And this is the kind of result we can get. The claw is corrected, the thumb is nicely up, and patient is able to reach to all the fingers, and he has got a good abducted position of the thumb, and that would be able to will be able to use the thumb for a lot of activities. Now, to conclude, again, I would like to emphasize and tell everyone that whenever you plan to do any tendon transfer, just think of these 3 questions. What is lost, what is required, and what is available. For median nerve, these are the functions which are lost, but you would only require to restore index flexion, thumb flexion, and thumb opposition. Index flexion can be reliably restored by side itching. Sometimes if index and middle both are weak, we can use the ECRL transfer to both of them. The thumb flexion can be restored either by brachyradialis or ECRL to FDP transfer. And thumb position, our first choice is the extensor indices transfer. And if it is not available, or if there is slight stiffness of the thumb, we could use for FTS transfer. However, whenever you are dealing with median nerve injuries, always give a lot of emphasis to the sensation. Because if the fingers are not having any sensation, even the best of the tendon transfers may not work well. So we restore sensation and then augment the function by doing the tendon transfers. Thank you.